Hi everyone. On today's topic we will be discussing about dermatological disorder named vitiligo. What is vitiligo, you asked? Vitiligo is an autoimmune cutaneous disease which commonly described as patches of discoloration or depigmentation. It is a heterogeneous condition with a complex pathogenesis. It can affect people of any race or ethnicity, however. Those with darker skin tend to be the ones most visibly affected by this condition. Even though tons of progress have been made during the research of vitiligo for the past several years, the pathogenesis and causes of this disease remain uncertain. Hence, it is characterized as idiopathic disorder. Moving on to the pathophysiology of this condition. Generally, the agreed principle of vitiligo involves the disruption of melanogenesis process, which mainly due to the lack of functional melanocytes or absence of melanocytes by the epidermis. Melanogenesis is a complex process by which the pigment melanin is produced in melanosomes by melanocytes. In vitiligo, the destruct melanocytes are primarily due to either by natural or unnatural reasons. Begin with the natural causes. The trait of self-destruction leads to a progressive decrease in melanocytes. There are multiple melanocyte destruction-related theories which includes genetics, autoimmune response, cytotoxic mechanisms, oxidant-antioxidant system, neural mechanisms, and intrinsic melanocyte defects. The most accepted theory is the autoimmune response, in which the activated immune cells decide to destroy melanocytes by itself, as well as the cellular immune mechanisms whereby the cytotoxic CD8 plus T cells are responsible for the destruction of melanocytes. Despite that, the autoimmunity theory of vitiligo is the most accepted, whereby none of the other proposed theories adequately explain accordingly to the diverse range of vitiligo phenotypes, but it's still debatable. In other cases, the unnatural factor that has been tied to vitiligo is either an exogenous or endogenous environmental stimulus. Example of exogenous stimulus includes UV exposure, cytotoxic chemical, other disease such as malignancies, and lastly, interaction with medication application. Whilst for endogenous stimulus, it is usually linked with the patient's condition, meaning that their hormone secretion may influence either progression or improvement of this condition when occurred.
Moving on to the clinical manifestation of sign and symptoms. In general, vitiligo tend to appear before the age of 30, whereby when the lesion appeared, it is usually in the shape of round, oval or linear, and often symmetrical. Next, the color of the macules is seen as milky white, and it is well defined. If present, it will emerge initially on the surface of the hands, around the face area, and at the private parts. Ultimately, some of the hair on the skin's surface may be affected by the lesion as well. It would be affected in the sense of it becoming prematurely white or gray, known as leukotrichia. Other than that, discoloration of the mucous membrane in the mouth and nose can also be a sign of vitiligo. The diagnosis for this condition is relatively straightforward. It begins with a physical examination and investigation of the patient's medical history. For example, observe the pattern of white macules present, patient's current medication therapy, family history of any other autoimmune disease, symptoms caused by the lesions, any latest chemical exposure, age correlation with onset of lesion, and others. Next step, this is crucial for patient with pale skin. This is because lesions on pale skin can be difficult to spot. Correspondingly, a Wood's lamp is necessary to help reveal the white spots much clearer. The light from the lamp will present a color of violet or purple. This indicates normal skin pigmentation, whilst for skin that has depigmented lesion, the light will turn to bright blue-white fluorescence. Lastly, dermatoscopy. This device aids in distinguishing vitiligo from other diseases that have nearly identical patterns of hypopigmentation. Vitiligo can be differentiated as it normally shows residual parafollicular pigmentation and telangiectasia, which are non-existent in other hypopigmentation disorders. Furthermore, it also helps in identifying the disease activity in vitiligo and the stage of evolution.
Now, how would we classify this condition? It can be divided into two major groups, segmental vitiligo and non-segmental vitiligo. For segmental vitiligo, it will present as soon as 6 weeks after birth, and in people age under 30. The occurrence is less likely to be associated with autoimmune disorders. It is also unlikely to occur compared to non-segmental vitiligo. The progressive loss of melanocytes can form unilateral patches of depigmentation which can be seen in a linear or block pattern. This type has mainly affected one body area, and it has a distinct demarcation around the midline of body. As for non-segmental vitiligo, it refers to all types that are not SV. There are several types. The most common types are the generalized and acrofacial vitiligo. This generalized vitiligo is widely distributed whereby the depigmentation of macules can appear anywhere on the body, commonly at trauma site. It may happen during childhood or even early adulthood. It can be distinguished by the pattern, which is bilateral and usually symmetrical shape. It could also spread widely, thus, the depigmentation can cover completely or almost completely all the body including hair, which is known as universal vitiligo. Now, to the next type, which is acrofacial or acral vitiligo, characterized by the depigmented macules. It is frequently limited to the head and distal extremities, which are body parts located further away from the center like hands and feet. If spread to other areas, this type can change its classification into generalized vitiligo. Jumping to the subcategory for acrofacial vitiligo, it is called as lip tip variety as the lesions are restricted to the cutaneous lips and distal tips of the digits. Next, hypochromic vitiligo or vitiligo minor. This type commonly happens to a person with much darker skin tone. Typically, the present hypopigmentation macules and a seborrheic distribution on the face and the neck can be seen. Sometimes, the hypopigmented macules can appear by the trunk of the body and scalp. This is due to the areas are rich with sebaceous glands. Last but not least, the mucosal vitiligo. On this subtype, it may affect the mucous membrane inside the patient's mouth or their genital tract. It is often described as unclassified vitiligo because it is rare to occur. This is a whole new part, which is known as mixed vitiligo. This normally occurs when generalized vitiligo develop in segmental vitiligo.
As mentioned in the pathophysiology, vitiligo happens because of the destruction of melanocytes and absence of functional melanocytes. Therefore, the goals of this treatments are to stabilize the depigmentation progress, ensure repigmentation of the lesions, and to maintain the persistence of the repigmentation once it has been achieved. There are 4 lines of treatments available to treat vitiligo. The first line of treatment is using topical treatments such as topical steroids and topical calcineurin inhibitors. Second line of treatment is by using phototherapy including NAROB and UVB, psoralen and UVA, and systemic steroid treatment. Third line treatment is using surgical grafting techniques. And lastly, depigmenting treatment, which act as the 4th line treatment for vitiligo. The therapeutic management of vitiligo can be divided into pharmacological treatment and non-pharmacological treatment. There are few pharmacological treatment available such as topical steroids, topical calcineurin inhibitors, antioxidants, vitamin D3 derivatives, and psoralen with UVA. The first one is topical steroid. It has an anti-inflammatory and immunomodulating effects. Secondly is topical calcineurin inhibitors, which has similar effects to topical steroid. It can be used as monotherapy or in combination with phototherapy to get a better treatment outcome. Next is antioxidant. It is being used to overcome oxidative stress experienced by the melanocytes. The 4th pharmacological treatment for vitiligo is vitamin D3 derivatives that help influences melanocyte maturation and differentiation while regulating the melanogenesis process via specific ligand receptor activated pathways. The final treatment is psoralen and UVA. Psoralen is administered orally or topically. Subsequently, the patient needs to expose themselves to artificial UVA radiation or natural sunlight, which is natural source of UVA for the psoralen to work. Another type of therapeutic management is the non-pharmacological treatment. One of it is NAROB and UVB treatment, or the short term for it, NVUVB. This treatment is for repigmenting vitiligo where it has immunosuppressive effects to reduce autoimmune melanocyte destruction. It can be used together with other pharmacological treatments such as systemic and topical steroids, topical calcineurin inhibitor, and Janus kinase inhibitors to guarantee a better outcomes for the patients. Moreover, sunscreen also can be used in vitiligo treatment primarily to protect the exposed skin from UVA and UVB. This is because vitiliginous areas can get sunburned easily and it may cause an extension of the repigmentation area. That is the end of this video. What a ride, huh? You can learn more by reading our literature review of this topic to find out more. Thank you for listening to this video.